If you're a student that struggles with scenarios or you're an educator that struggles to come up with them, then this is the book that you need. This is 100 patient scenarios, literally 100 patient scenarios in this book on all different categories, and it's going to allow you to prep, conduct, and debrief all 100 of these scenarios. It's all available for you at the link in our bio. So we're going to start off by looking at the inferior myocardial infarction, and then we're going to move throughout the heart in order to talk about different areas that are going to have different effects on the heart itself. So the inferior myocardial infarction, the classic way to look at an inferior myocardial infarction is to look at the leads 2, 3, and AVF. We're also going to talk about another lead that is very important when it comes to inferior myocardial infarctions as well. In fact, it can catch even earlier starts of inferior myocardial infarctions by looking at this particular lead. So whenever we're looking at an ECG and we're looking at S&T elevation and we're looking to confirm these types of suspicions, we always do what we do in making sure that we have the congruence, which means that we have separate leads that are also showing the same thing, which is above 1 millimeter of S&T elevation. So in this particular case, we have lead 2. Lead 2 isoelectric line is here. We have the J point in here, and we have 1, 2, almost 3 mils of elevation in this particular lead in lead 2. Lead 3, we have an isoelectric line, and then we have a J point in here, and that means we have 2 mils of elevation in lead 3. Lead EVF, we have the isoelectric line here. It's a little bit below that mark. And then we have the J point here. That is 1, 2, to about 2.5 boxes or 2.5 mils of elevation. So in this particular case, we have congruent leads or consistent leads looking at the same area of the heart that are suggesting over 1 mil of elevation. This would be positive confirmation of a S&T elevated myocardial infarction. So just to give you an idea of where this is actually looking. So when it comes to inferior myocardial infarctions, remember, a lot of people have a really heavy look at talking about that right ventricle, and that the inferior myocardial infarction is 100% tied to that right ventricle. And that's actually not a true statement. Just because you have inferior myocardial infarction does not mean that that right ventricle is heavily affected. About 40% of inferior myocardial infarctions will have significant impact on that right ventricle. But again, we need to do more confirmation in order to really take a good look at that. Now, why is this important? Well, inferior myocardial infarction isn't looking directly at that right ventricle. What it's looking at is it's actually looking at the bottom portions of the heart like so. And it just so happens that those inferior leads are looking at here, here, and a little bit off to the here. So we're looking at 3 different locations, truly, of the bottom portions of the heart. So that's what the inferior myocardial infarction or the leads 2, 3, and AVF are looking at. They're looking at the bottom portions of the heart, and just so happens that it gets a very good view of the bottom portions, this inferior portions of this right ventricle, but it also gets a viewpoint of a lot of the septum or the inferior wall, the side wall here of that left ventricle. So those are important things to take in consideration. So just because you have inferior myocardial infarction does not mean that right ventricle is 100% affected. There are other things to take in consideration here as well. So that's what we've kind of talked about when it comes to the heart. Now, what vessel is actually being affected here? Well, it's going to be the right coronary artery. And this right coronary artery comes off here, and it makes its way kind of and wraps around. In 80% of the population, it wraps itself around in order to feed the posterior portions of the heart. And so that's basically what we're seeing here, is that it's this right coronary artery is coming around and then wrapping around the posterior portions of the heart. And like I said, it feeds the inferior portions or that bottom portion of that right ventricle. And that's how, because it has a branch that's kind of come running along the line of that right ventricle, as you can see here. If I put that up, you see branches that are running here that are branching out to those inferior portions of the heart. That's 80% of people that are going to have this extension. Now we can have a different one, which is the other, 18%, which is the left circumflex. Now the left circumflex is over here, and it branches off the left main and branches off like so, and then wraps around the heart and then feeds the posterior portions, as well as branches off to the inferior as well. So that's what we're seeing here in inferior myocardial infarctions. Like I said, 80% of these people are going to have infarctions of this right coronary artery, with the other 18% left circumflex that's wrapping around to the inferior portions of the heart, and that other 2%, 1% of people have just abnormal anatomy, which can be kind of wraparound left anterior descendings, those types of things that are a little bit uncommon. So that is what's going on as far as the vessels being blocked and vessels being affected that are causing your infarction. So one lead that I did mention that we want to look at, opposed from the 2, 3, and AVF, which are the traditional inferior leads, is this one called AVL. Now, AVL is an interesting one, and it's usually sitting right in here. Okay, we don't use AVL very often, but it just so happens it has a great view. So AVL is kind of up in here. Okay, and it's looking kind of at this view like so. I'll change the color so you can see exactly what I'm seeing. It's coming down like so, and it's looking at this wall here because it's such a high lateral. So it ends up looking through the heart like so against this lateral wall of this right ventricle. So it can get a very good view. So if I go back here and look at this ECG, this is the same ECG that we looked at before with the inferior S&T elevated MI, okay, with 2, 3, and AVF. But if you'll look at AVL, you'll notice that we have flip T's and we have S&T depression. So this is the isoelectric line here. And then the J point is in here, which is about 1 to 1.5 mils of depression. Okay, now if we were to, and this is suggestive of a reciprocal change, because again, AVL is looking through the heart and seeing a reciprocal change on the opposite side of the heart like so. So that is what we're seeing here, which is quite interesting when it comes to the viewpoints that we're getting here. In fact, AVL can pick up S&T elevated myocardial infarctions prior than 2, 3 AVF. It just so happens that it can catch those early myocardial infarctions prior to S&T elevation. So don't ever forget to look at AVL when you're looking at an ECG. And if you have abnormalities like S&T depression, this is a very good indicator that we may have an inferior myocardial infarction. And then that means that we may have a good reason to do a V4R, which is taking V4 here and swapping it to the other side. And what that does is it gets us a very good direct viewpoint directly at that right ventricle wall to see how much it's being affected. And if we see S&T elevation in V4R, that tells us that we have significant myocardial damage to that right ventricle in particular. So those are the leads that we're going to be looking for here as far as AVL and 2, 3 AVF in order to confirm, like I said, inferior myocardial infarctions that are dominantly affecting that right coronary artery. That right there is $785 worth of textbooks. You're going to be asked to purchase a lot of these when you join EMT and paramedic school. This is Master Medics. MasterMedics is an online learning tool made specifically for EMT and paramedic students. We've had 10,000 students come through us to transfer this textbook knowledge into their minds. And it works because it's fun, it's visual, and it's engaging. And if you want to try it out for yourself, you can start a 3-day free trial right now at the link below. So something interesting can happen here as well, which is a bradycardia that happens in inferior myocardial infarctions. So in about 20% of patients, 20% of inferior myocardial infarction patients will have symptomatic bradycardia. Why is that? Well, it just so happens that this right coronary artery that's kind of wrapping around like here, it just so happens that some of the branches on the proximal portions or the top portions of this right coronary artery are feeding the SA node and particularly the AV node. Okay? So feeding the SA node and feeding the AV node. So in those particular cases, those branches that have feeding capabilities to those nodes, if we see symptomatic bradycardia in inferior myocardial infarction, if we see bradycardia here, this is a good indication that we actually have a really high blockage here, a really high blockage, because those branches are quite high in that right coronary artery. So if we see a blockage really that's causing bradycardia, you can suspect that that blockage is really high above those branches that are causing an ischemia to those nodes. That's why bradycardia can happen in myocardial infarctions, and 20% is not a small number. This is quite a few patients that are going to have bradycardia due to these inferior MIs. So this is all leading towards how do we treat this patient? Well, in an inferior MI, typically, like we said, we're having the right ventricle that's going to be affected. Okay, I have this right ventricle that's going to be affected, and portions of this lateral wall or the inferior wall of the left ventricle itself. So, but we're going to focus on this right ventricle that's going to be predominantly affected in an inferior MI, especially if we confirm it with V4R and AVL as well, which is looking at this lateral wall here. So what happens when we have a right ventricle that is affected, that's losing its ability to pump because its myocytes are now infarcted? Well, here's an interesting thing about the right ventricle is that it doesn't have a lot of muscle. You can see a little bit here. You'll notice that the muscle wall is quite thin here, and most of the muscle is dominantly on the left ventricle. Why is that? Well, truthfully, is because of the locations in which we need to pump. Think about it this way, is that left ventricle is going to pump blood to the entire body. Okay, it needs to have a high pressure system and a lot of contractility in order to achieve that. And so the left ventricle predominantly needs a lot more muscle in order to achieve its goal of perfusing the entire body. Whereas the right ventricle is only going towards the lungs. And so it doesn't need to rely on high pressure systems in order to pump a long distance. And so it just doesn't need nearly as much muscle to achieve its goal. And what it relies more on is preload. And preload is that fluid that's inside that right ventricle prior to contraction. And so this right ventricle is going to dominantly try and maintain a lot of preload in order to push blood, because since it doesn't have so much muscle, it's just going to fill the tank as much as it possibly can, so that way it doesn't need to use so much muscle to move blood forward. That is how that right ventricle operates in a normal physiological state. Now, what happens when we have a myocardial infarction and we lose some of this precious muscle? We end up losing a good portion of this muscle, which means that that ventricle is going to have a heck of a time trying to contract and move blood forward, even if we do have good preload. So we really have a major impact on contractility. And that contractility is having a huge hamper on cardiac output, because without the ability to pump blood forward into the lungs, it means that we're going to have less blood that's going to pump back here in this left ventricle. Because if blood's not moving forward, it's certainly not draining here as well, which is going to have an impact on systemic circulation and ultimately a decrease in perfusion or mean arterial pressure. So that is the issue that we're dealing with right now, is an inability to contract regardless of how much blood we have inside this ventricle, and we have a decreasing cardiac output, and that decreasing cardiac output, because of the factor of contractility, is impacting our ability to perfuse the body, and that is how we have an issue with inferior myocardial infarctions. And in some cases, in 20% of those cases, like we saw, if those AV nodes or SA nodes are affected, we even have a decrease in heart rate, okay, which is going to even impact cardiac output even further, and thus decreasing our mean arterial pressure. So we have some pretty serious problems here that we need to correct. Now, what's going to compensate in these patients? Well, we're going to try and have a increase in systemic vascular resistance. But remember, systemic vascular resistance is all about the vessels clamping down or constricting and basically maintaining more pressure against the fluid that's in those vessels. But the problem is that we have an inability to move blood into the arterial system. All this blood, all this fluid is trapped on the venous side because this ventricle can't contract. So really, when we try and squeeze our blood vessels on the arterial side, it ultimately isn't going to be squeezing against anything because all that fluid is redistributed on the venous side, the venous side. And so it doesn't matter how much we constrict those blood vessels. If there's no fluid there, we don't maintain any resistance, which means it's not going to have a big compensating factor on improving mean arterial pressure. So that's why we often see bradycardia or a potential of bradycardia in inferior myocardial infarctions. So what is our goal knowing the physiology here? Well, the goal is to improve cardiac output. Improve cardiac output. So there's a few ways that we can do that. We can improve the heart rate to improve cardiac output, or we can improve the stroke volume to improve cardiac output. Those are the two main ways that we can improve cardiac output. So what are we going to do in inferior myocardial infarctions? Well, first thing is that, remember, this ventricle relies on preload as it is. Okay, and now we have a damaged cardiac muscle that is unable to push the blood that it already has. So what we're going to do is that we're going to play its normal physiological role against it. And so what we're going to do is that we're going to introduce fluids, isotonic fluids. And what isotonic fluids are going to do is it's going to improve the preload, or the concentration or volume of fluid inside that right ventricle prior to contraction. And by doing this and increasing preload, we can hopefully increase our stroke volume, because even though we have damaged muscle tissue, we know that if we increase preload, we can at least move some extra blood forward every single time it contracts. Okay, so that is a good thing. And the nice thing about increasing preload, when we increase the preload itself, what's going to do is that we're going to actually have a positive effect on Starling's law. Not a great effect because we know those muscles are damaged, but when we increase the volume inside a ventricle prior to contraction, we stretch out myocytes. And when we stretch out good myocytes, even though we have some dead ones, we have infarcted ones, we do have some good ones in that ventricle. And when we stretch them out a little bit more, they actually have a rebound effect and create more contractility. So by introducing more preload, we're actually going to marginally improve contractility as well, which hopefully will start to have an impact on cardiac output. Okay, so those are the things that we're going to start off with when it comes to inferior myocardial infarction in order to solve this problem. Obviously, our first lines like giving oxygen, patients that we're going to give ASA, but we're going to look at really giving fluids in order to solve the problem that we have here. Now, what are some other things that we can do in order to solve this problem? After we've given fluids and we still, let's say we still have hypotension, well, then we need to look at other things that we can hopefully improve. If we have a bradycardia, then we can look at correcting that bradycardia by introducing things like pacing, things like epinephrine, those kind of things to improve cardiac output, by improving the heart rate itself. And so that's something that we can look at as well in order to improve more cardiac output. So it really depends on what you're seeing here, because if you have bradycardia, that's precipitating to your drops in blood pressure along with the decreases in contractility. And so those are the things that we need to correct. But the goal in an inferior myocardial infarction is to correct this problem, is increasing the cardiac output, which in turn will increase the mean arterial pressure. Now, you might have noticed that I've left off a medication that we use quite a bit in acute coronary syndromes, which is nitroglycerin. And so my question to that we get a lot when it comes to inferior myocardial infarctions is nitroglycerin contraindicated in these patients? And the answer to that question is it depends. So it really depends on what you're seeing from a muscular standpoint or from a right ventricle standpoint. So typically in inferior myocardial infarctions, we often are going to withhold nitroglycerin. And here's the reason, is that we know that, just like we saw in the physiology, is that our patients that have a inferior myocardial infarction typically are going to have the right ventricle involved, which means that they have a preload problem. They have a problem pushing blood forward. And so we want to maintain as much preload as possible in that right ventricle, so that way we can propel blood forward to the lungs and maintain circulation. So in patients that have inferior myocardial infarctions, about 40% of those patients, 40% of those patients will have be preload dependent, meaning that they need to maintain this blood in this ventricle. And if they don't, then they're going to have significant drops in blood pressure and mean arterial pressure. So if we give a nitroglycerin to those 40% that have major preload dependency, then we're going to cause major drops in blood pressure. This is why inferior myocardial infarctions, we often hear that we're not going to give nitro to these patients. Mostly because of these preload things, as well as the fact that we can cause hypotension. Or if the patient is already hypotensive and we give nitroglycerin, we're leading them down a path we don't want to go. So is nitroglycerin contraindicated? It depends. What's a good way in order to determine whether that right ventricle is truly involved and we shouldn't give nitroglycerin in these cases, is actually looking at a V4R. Now remember, V4 is looking predominantly at the anterior portions of that left ventricle. So what we're doing for V4R is we're taking V4 ECG lead, taking it and putting another sticker on the right side of the chest, and so that way we can get a direct view of the anterior portions of that right ventricle. And if we do that, then we are going to see how much that ventricle is actually having problems contracting. So in these particular cases, you'll see V4R here, okay? They've circled it and suggested it here. So you can take the isoelectric line like we always do, and then we take our J point, and that's kind of way up here. So in this particular case, we are looking at about 3 mils of elevation there, suggestive of a S&T elevation in V4R, confirming our right ventricular infarct or right ventricular involvement and muscular damage. So in this particular case, if we have this and we know that that right ventricle is damaged, then nitroglycerin is contraindicated, because we know that if the right ventricle is this damaged, then they are 100% absolutely preload dependent and require the avoidance of nitroglycerin and require preload, which we know nitroglycerin is going to cause a decrease in. Now, I should mention, when it comes to inferior myocardial infarctions, is that in these particular patients, we know that they are already preload dependent. Even in patients that have that don't have V4R, that's actually have S&T elevation, inferior myocardial infarction patients, their problem is preload. Their problem isn't afterload, which is really what nitroglycerin is going to help, is afterload by causing vessel dilation, and it's going to decrease preload to achieve that effect. So nitroglycerin is a useful medication in patients that have left ventricular infarctions, and patients that have anterior MIs and so on and so forth that have significant pulmonary edema, that have significant afterload problems. Those are the patients that nitroglycerin really can benefit a patient. And truly, when it comes to a patient that has an inferior myocardial infarction, is a totally different physiological problem. And so nitroglycerin, to this day, really has a very controversial impact on ACS in general, especially inferior myocardial infarctions. And the theory behind giving nitroglycerin to any ACS patient is that we can cause some coronary artery dilation, which means that we can increase blood flow. But truth be told, in medication, in nitroglycerin, we don't have a huge impact on the coronary artery dilation. It just doesn't, because nitroglycerin is going to have a much bigger impact on venous dilation. And venous dilation is what's going to decrease preload. And so venous dilation is an issue when it comes to inferior myocardial infarctions. And so we might have a marginal increase in dilation of those coronary vessels, but in a patient that has a complete blockage, that marginal dilation is a low positive with how much risk is involved with trying to get a marginal dilation in coronary vessels, when we know that we're going to have a big risk in causing preload problems in these patients. And so the risk benefits here are pretty out of whack, and why nitroglycerin likely shouldn't be used in inferior myocardial infarctions, simply because of this fact.